Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. A very important topic today about iron deficiency anemia in pregnancy. So, what are the objectives of this lecture? Before I start, this lecture guided by the United Kingdom Guidelines on the Management of Iron Deficiency in Pregnancy 2019. So our objectives include definition, iron deficiency anemia, the prevalence, clinical effects of iron deficiency anemia in pregnancy, diagnosis, management of iron deficiency during pregnancy. Okay? Okay. Let us start with the definition. What is anemia in pregnancy? Anemia in pregnancy is defined as a low hemoglobin concentration if below 11 gram per deciliter in first trimester, or if hemoglobin below 10.5 gram per deciliter in second and third trimester, or if hemoglobin level below 10 gram per deciliter postpartum. And you shouldn't be confused if you found some little difference in the definition of American College of Obstetrician and Gynecologists or WHO, because there is very little difference. Okay, this is according to the Royal College. This is the definition. Of course, we know that the hemoglobin is changeable during pregnancy due to increased plasma volume. Okay, so as I said before, again, anemia in pregnancy is defined as low hemoglobin concentration if less than 11 gram per deciliter in first trimester, if less than 10.5 gram per deciliter in second and third trimester, if it is less than 10 gram per deciliter postpartum. Okay? And also we should know that iron deficiency is the most common cause of anemia in pregnancy. Not only in pregnancy, all over the world. Okay? Iron deficiency is the most common cause of anemia. Specifically in pregnancy, which result in microcytic and hypochromic red cells on the peripheral smear. And you should know also that iron passes through absorption into two different pathways, either heme or non-heme. Heme, I mean with heme iron that present in meat, liver, poultry, fish. Non-heme iron present in cereals, legumes, okay, eggs. So, what is the most absorbable form of iron? Ferrous is the absorbable one. Ferric is less absorbed. So, for iron salt to be absorbed, it must be in ferrous form. Okay? And this happens physiologically under the effect of the acidity and the pH, low pH of the stomach, change the ferric to ferrous, make it more absorbable. Okay? Okay, you should know this item. Also, another item, where is the site of GIT where iron is absorbed? Iron is absorbed in the duodenum, and the proximal jejunum. Okay? Okay. So what about the prevalence? The prevalence of maternal anemia approach 50% in low and middle income countries, largely due to a combination of nutritional deficiency, infectious diseases, and the presence of variant hemoglobin or thalassaemic disorder. But in United Kingdom, the prevalence of anemia was found to be 24% in a multi-center national study. So, prevalence of maternal anemia approached 50% in low and middle income countries. And this is, of course, a very big prevalence. So, should be managed. Okay, what is the clinical effects or complication of iron deficiency anemia in pregnancy? Iron deficiency anemia is associated with poor quality of life, maternal fatigue, altered thyroid metabolism. You will find lower thyroid stimulating hormone and T3 hormone with iron deficiency anemia. Also, there is increased risk of postpartum depression, postpartum hemorrhage, puerperal sepsis. Also, if severe anemia, hemoglobin less than 7 gram per deciliter antenatally or postpartum, this could lead to twofold increase in mortality in low and middle income countries. Okay, maternal anemia has been associated also with a significant higher risk factor of intrauterine growth restriction, low birth weight, preterm birth, stillbirth, perinatal and neonatal mortality, impaired motor, cognition, and language development in the neonate in certain cases. Okay? Okay. This is as regard the clinical effect of iron deficiency during pregnancy or what you consider complications. Let us say what the guidelines said in summary. Healthcare professionals should be aware that iron deficiency anemia in pregnancy is common and associated with increased risk of maternal and perinatal morbidity and mortality. This is very important and should be managed very well to avoid this morbidity and mortality. What about the diagnosis of iron deficiency anemia during pregnancy? Three very important items: the clinical symptoms and signs, the laboratory testing, trial of oral iron as a diagnostic test. It can be also diagnostic and the therapeutic test. Okay? So let us start with the first item, the clinical symptoms and signs. The most important symptom is the fatigue, or the most common symptom. The most common symptom for iron deficiency anemia during pregnancy is the fatigue. What else? Pallor, weakness, headache, palpitation, dyspnea, dizziness, irritability, poor concentration, and restless legs. Hair loss sometimes, craving for non-food items such as ice, what's called bagophagia, and the soil like geophagia may develop. The craving to non-food items by the female, she need to eat ice or frost, nutrients or something like that. This is called bagophagia. Also, other female may need to take soil, what's called geophagia. These symptoms may develop in some cases. What is the lab testing? The second important item in diagnosis. First, check hemoglobin during pregnancy with the first antenatal care visit, during booking. At booking appointment, you should ask for serum hemoglobin. What is it? The hemoglobin level. And you should repeat it at 20 weeks age, gestational age. So, at booking appointment, then at 20 weeks gestational age. What is the expected finding? A low hemoglobin, mean cellular, mean cell volume, mean cell hemoglobin, and the mean cell hemoglobin concentration all decrease, and suggestive of iron deficiency. And you can see the difference between normal erythrocytes and microcytes. We know that iron deficiency anemia causing microcytic hypochromic anemia with decrease of hemoglobin, mean cell volume, mean cell hemoglobin, and the mean cell hemoglobin concentration. As you see here, this is smaller in volume, less hemoglobin, and less hemoglobin concentration. This is the microcytic hypochromic anemia, characteristic of iron deficiency anemia in this area. What else in lab testing? A low serum ferritin. A low serum ferritin less than 30 microgram per liter is diagnostic of iron deficiency in pregnancy. However, normal ferritin level doesn't exclude iron deficiency. Why? Because pregnancy is associated with the physiological changes in iron metabolism. Okay? But still, we should know that low serum ferritin below 30 microgram per liter is diagnostic of iron deficiency in pregnancy. The test item to reach the diagnosis, I said symptoms and the signs of iron deficiency anemia, then lab test, then by measuring the hemoglobin at booking appointment and at 20 weeks gestational age, and doing serum ferritin level. If it is less than 30 microgram per liter, indicative of iron deficiency anemia. But of course, it is not done for all cases. It is not done as a routine, I mean. The third item for diagnosis is trial of oral iron. Trial of oral iron could be diagnostic and therapeutic at the same time. In anemic women, oral iron is recommended at early morning on an empty stomach. So, to be efficient, because absorption is more better if it is given early morning on an empty at early morning on an empty stomach. A trial of iron therapy for simultaneous diagnostic and therapeutic purposes is helpful. What do you expect from this oral iron? To increase the hemoglobin after 2 weeks. And if this happens, this supports the diagnosis of iron deficiency. So your test is positive. Yes, this is a case of iron deficiency anemia, because when I gave an oral iron supplementation by the proper way and the patient was compliant, yes, there is rise in hemoglobin, so this is diagnostic that this case was an iron deficiency anemia. If there has been no improvement in hemoglobin following the 2 weeks of optimal therapy and the compliance, more definitive testing and the treatment is required. So you are in need for more investigation. and maybe a modification of your treatment. Okay, one important thing is women who are hemoglobinopathy carriers should have serum ferritin testing prior to iron administration to confirm concomitant iron deficiency and exclude iron overload. So, in very special cases with hemoglobinopathy, you should do test for serum ferritin before you start oral trial oral iron therapy. Okay, you should do test for serum ferritin to confirm concomitant iron deficiency and exclude iron overload, because there may be concomitant iron deficiency in such cases or not. So you should know to avoid iron overload. Okay, so important question here. What about non-anemic women with high risk of iron depletion? Should I give her iron therapy, iron treatment, and should I do serum ferritin test for her or not? So non-anemic women with high risk of iron depletion for empirical iron treatment with or without serum ferritin test. Who are such category? Previous women with previous anemia, multiparity, more than para 3 or para 3 or more, twin or higher older multiple pregnancy. If inter-pregnancy interval less than 1 year, those following a vegetarian diet, women who have a poor dietary habits, pregnant teenagers, recent history of clinically significant bleeding. So, those women need to be given empirical iron treatment with or without serum ferritin testing, although they are non-anemic, but they are high risk for iron depletion. Okay? Okay. Okay. What about non-anemic women where serum ferritin may be necessary? The guidelines said it should be done serum ferritin in non-anemic women in this situation. Those high risk of bleeding during pregnancy or at birth, women declining blood products such as Jehovah Witnesses, certain or a special group of women, in their belief, they never accept blood transfusion or blood products or bagged RBCs. So this woman should take a very special care. I should do serum ferritin for those patients to know if they are diagnosed as iron deficiency anemia or not, and the stores is depleted or not. What else? Women for whom providing compatible blood is challenging. If there is difficulty to find compatible blood for transfusion, those women should have test for serum ferritin. Okay? Okay. And diagnose iron deficiency anemia early and correctly. So this is the three indication for non-anemic women where serum ferritin may be necessary. Let us go to the diagnosis of iron deficiency anemia during pregnancy, the guidelines. The recommendation of Royal College. Healthcare workers should be aware that iron deficiency is the most common cause of anemia in pregnancy, and the risk of iron deficiency should be considered in all pregnant women. Hemoglobin concentration should be routinely measured at booking and at around the 28 weeks gestational age, as I said before. Systems must be in place for timely review of blood test results, including monitoring the response to therapy. If anemia without an obvious other cause is detected, a diagnostic trial of oral iron should be given without delay, with a repeat full blood count in 2 to 3 weeks. The optimal diagnostic strategy for anemia in pregnancy is unknown, but unselected routine screening with serum ferritin outside the context of research is not currently recommended. So, serum ferritin test is not a routine screen test. Okay, please remember this. There is certain indication to do it, as I said before. Serum ferritin should be measured in women with a known hemoglobinopathy to identify concomitant iron deficiency and exclude iron loading state. Non-anemic women at risk of iron deficiency should be identified and either started on prophylactic iron empirically or have serum ferritin checked first. Serum ferritin level of less than 30 microgram per liter in pregnancy is indicative of iron deficiency. Levels higher than this don't rule out iron deficiency or depletion, as I said before, because of physiological changes in metabolism of iron during pregnancy. Other biomarkers of iron status are not currently recommended for screening as there is insufficient validation in pregnancy. There is other biomarker and the research are running about them, but up to now there is no recommendation to do it as a test during pregnancy. Let us go to management of iron deficiency during pregnancy. You can divide them into dietary advice, oral iron preparation, intravenous iron therapy. What about dietary advice? Okay, what is the average daily iron intake from food? In the United Kingdom, they found that the daily iron intake in food reach up to 10 milligram. But you should know that 10 to 15% only absorbed. So, in the food there is an average 10 milligram iron, but only 10 to 15% is absorbed. So about 1.5 milligram is absorbed daily. And this is the elemental iron. The capacity for absorption is enhanced in pregnancy, but physiological iron requirement increase from 1 to 2 milligram up to 6 milligram per day. So if in non-pregnant 1 to 2 milligram is sufficient for non-pregnant women, in pregnant women it increases up to 6 milligram per day. With increasing demand as pregnancy advances. We know that iron is important for DNA synthesis, for electron transport, for oxygen transport, for the function of certain enzyme. Okay, for formation of hemoglobin. Okay, so iron has many functions in the body, and there is increased demand as pregnancy advances. What are the items or nutrition or vitamins that decrease or increase the absorption of iron? It was found that vitamin C significantly enhance iron absorption from non-heme foods. And you should know that iron absorption has two pathways, through heme foods or non-heme foods. What heme foods? Heme foods, iron present in meat, poultry, fish, and so on, combined to protein. But non-heme foods is the iron present in cereals, legumes, seeds, nuts, eggs. Okay, this is the difference between non-heme and the heme. Heme foods like meat, as I said, poultry, fish, and so on. Non-heme foods in cereals, in seeds, in legumes, in eggs. This is called non-heme foods. So vitamin C significantly enhance iron absorption from non-heme foods like cereals, legumes, seeds, nuts, and eggs. On the other hand, tannins in tea and coffee inhibit iron absorption when consumed with meal or shortly after. That's why you advise the pregnant lady not to take tea or coffee during lunch. Tea or coffee should be separated from the diet more than 2 hours, not with the diet or immediately after the diet. So avoid the bad habits of drinking tea and the coffee after lunch or breakfast immediately or during lunch or breakfast. You can delay it for 2 hours or more. Why? Because it decreases the absorption or inhibit iron absorption. Okay, let us go to the recommendation of guidelines for dietary advice. In summary, all pregnant women should receive dietary advice. Once women become iron deficient in pregnancy, it is not possible to ensure repletion through diet alone, and the oral supplementation is needed. Education and counseling regarding diet may improve iron intake and enhance absorption, but the degree of change achievable, achievable remains in question. Okay, what is oral iron preparation? Ferrous, ferrous salts are preferred to ferric salts due to poorer absorption and the bioavailability of the latter. Ferrous salts, iron plus 2, are more absorbable and more bioavailability. So, is the preferred one, the ferrous salts. Ferric salts is iron plus 3, is poor in its absorption, poorer in absorption and the bioavailability. So we will depend on ferrous salt, not ferric salt. Available ferrous salts include ferrous fumarate, ferrous sulfate, ferrous gluconate, and you should know that it is the amount of elemental iron that is important, and this varies by preparation. So each salt of this ferrous fumarate, ferrous sulfate, ferrous gluconate give different elemental iron, which is the most important. Like in this table, you can see here the recommended daily dose and the elemental iron content of oral iron preparation. As you see, in this iron salt, ferrous fumarate, the preparation contains 210 milligram, give only 65 milligram elemental iron, while ferrous gluconate in preparation containing 300 milligram give 35 milligram elemental iron, while ferrous sulfate in preparation 200 milligram gives 65 milligram elemental iron, while ferrous ferritate 190 milligram and 5 milli elixir gives 27.5 milligram per 5 milli elixir. Again on oral iron preparation. Until now, the recommended dose of elemental iron for treatment of iron deficiency has been 100 up to 200 milligram per day. However, more recent studies suggest that lower doses or intermittent supplementation may be advantageous. Higher doses potentially increase side effects due to the excess unabsorbed iron remaining in the gastrointestinal tract. Iron is known to cause gastric irritation, nausea, and disturbed bowel function, affecting compliance. And this is very important. You may prescribe iron for the patient, and she didn't take it because of the side effects. So, when you do follow up for a pregnant lady taking oral iron supplementation, you should be careful that the patient is taking the treatment regularly and she didn't stop it because of side effects. Okay? So, let us go to the summarized guidelines. Ferrous iron salts are the current preparation of a choice for oral iron supplementation. Until further research determine the optimal dose of elemental oral iron, 40 to 80 milligram every morning is suggested. Checking hemoglobin after 2 to 3 weeks to ensure an adequate response. So, the recommended or the optimal dose up till now of oral iron 40 to 80 milligram every morning. Okay, this is the suggested dose until the guidelines prove this again. Okay, and you must check hemoglobin after 2 to 3 weeks to ensure that there is adequate response. Women should be counseled as to how to take oral iron supplements correctly. We should advise her to take it on an empty stomach with water or a source of vitamin C. Source of vitamin C may be lemon juice, for example. She can take the oral iron with lemon juice or with water on an empty stomach. This is the best for iron absorption. Other medications, multivitamins, and the antacids shouldn't be taken at the same time. So other medication, multivitamins, and antacids shouldn't be taken at the same time, so not to affect the iron absorption. Treatment for anemia should be started promptly by healthcare professional caring for the woman. But sometimes I need specialist medical care. If anemia is severe, hemoglobin less than 7 gram per deciliter, and or associated with significant symptoms or advanced gestation more than 34 weeks, or if the hemoglobin is failing to respond after 2 to 3 weeks of oral iron correctly taken. So, ask for consultant medical care for certain women with advanced gestational age and still there is iron deficiency anemia. Advanced gestational age means more than 34 weeks gestational age, or not responding to oral iron up to 3 weeks, or the patient has significant symptoms of iron deficiency anemia. In non-anemic women at increased risk of iron depletion, 40 to 80 milligram elemental iron once a day should be offered empirically, or serum ferritin should be checked and the iron offered if ferritin is less than 30 microgram per liter. Okay? What about response to oral iron? The degree of increase in hemoglobin that can be achieved with iron supplements will depend on the hemoglobin and the iron status at the start of supplementation. Ongoing losses, iron absorption, and the other factor contributing to anemia, such as other micronutrient deficiencies, infections, and renal impairment. These other factors may affect the condition. Okay. However, compliance and intolerance of oral iron preparation are the usual factors limiting efficacy. So be careful to do follow-up for such patient and to know if she is compliant. She is following the regimen of dose you prescribed for her of oral iron and taking it regularly or not, because some of them may stop it due to side effects. It may be necessary to titrate the dose down to a level where side effects are acceptable or try an alternative preparation. Suppose the patient told you, I have a problem in GIT due to oral iron preparation, and I stopped it. Either you change the iron salt or give her in a different dose, smaller dose, or try day after day dose, and so on. So be malleable in this, either changing the iron salt preparation or changing the dose or giving her day after day. Very important for you to know that enteric-coated or sustained release preparation should be avoided, as the majority of iron from such preparations is carried past the duodenum, limiting absorption. We know that most of the iron absorbed in the duodenum and the proximal jejunum. When you are using enteric-coated tablet or sustained release preparation, they pass the duodenum and jejunum before absorption. And the maximum site for absorption of iron is the duodenum and the proximal jejunum. So, please, enteric-coated or sustained release preparation should be avoided. This is important information to be known for all obstetricians. A repeat hemoglobin after 3 weeks, 2 to 3 weeks, is required to assess the response to treatment. As I said before, the timing of further check will depend upon the degree of anemia and the period of gestation. Once the hemoglobin is in the normal range, treatment should be stopped or continue. Treatment should be continued for a further 3 months and until at least 6 weeks postpartum to replenish iron stores. Because iron stores may be depleted, I want to replenish, make it reach iron stores. So, and if the hemoglobin is corrected, becomes in normal range, I should continue for a further 3 months and until at least 6 weeks postpartum to replenish iron stores. Let us go to the summary of the guidelines. For response to oral iron, for nausea and epigastric discomfort, alternate day dosing or preparation with lower iron content should be tried. Slow release and the enteric-coated form should be avoided. We said that before. but this is the summary of the guidelines. Repeat hemoglobin testing is required 2 to 3 weeks after commencing treatment for established anemia to assess compliance, correct administration, and response to treatment. Once the hemoglobin in the normal range, replacement should continue for 3 months and until 6 weeks postpartum to replenish the iron store. If response to oral iron replacement is poor, compliance should be confirmed and concomitant causes that may be contributing to anemia considered, such as folate deficiency or malabsorption. If there is no response, there may be another problem. There may be folate deficiency. There may be malabsorption syndrome. What about intravenous iron therapy? Systematic review and the meta-analysis found that pregnant women receiving intravenous iron compared with oral iron achieved the target hemoglobin more often, had an increased hemoglobin after 4 weeks, and had fewer side effects. Intravenous iron therapy is indicated when there is absolute non-compliance with or intolerance of oral iron therapy. So, intravenous iron therapy is indicated when there is absolute non-compliant or intolerant patient for oral iron therapy, or in cases proven to have malabsorption syndrome, because the absorption of iron is defective, so intravenous iron is indicated. The third indication, when rapid hemoglobin response is required. This is the 3 indications for intravenous iron therapy. What is the contraindication for intravenous iron therapy? A history of anaphylaxis or serious reaction to parenteral iron therapy. If you give the patient before intravenous iron and the anaphylaxis happen or serious reaction happen, so you shouldn't give iron intravenous anymore. What else is a contraindication for intravenous iron? First trimester of pregnancy. Don't start intravenous iron during the first trimester of pregnancy. Only in second and third trimester you can give iron therapy. And of course, postpartum. But first trimester is contraindicated. Active acute or chronic bacteremia is another contraindication for IV iron therapy. Decompensated liver disease, those with liver cell failure or severe cirrhosis, don't give this patient intravenous iron therapy. This is the contraindication of intravenous iron therapy. So we now know the indication and the contraindication for intravenous iron therapy. So what about the preparation of intravenous iron therapy? Iron sucrose has a higher availability for erythropoiesis than iron dextrane, and the experience suggests a good safety profile in pregnancy. Its use is limited by the total dose that can be administered in one infusion, requiring multiple infusions. So it has advantage, but has disadvantage. Again, iron sucrose has a higher availability for erythropoiesis than iron dextrane, and experience suggests good safety profile in pregnancy. This is the advantage of iron sucrose. But the disadvantage, its use is limited by total dose that can be administered in one infusion. If you wanted to give total dose in one infusion, you cannot. You need multiple infusions. This is as regard the iron sucrose and its advantage over dextran and the disadvantage. Iron carboxymaltose and the iron isomaltoside. Isomaltoside. Iron carboxymaltose and the iron isomaltoside overcome this problem, allowing single dose administration. So, iron carboxymaltose and iron isomaltoside allowing single dose administration. So the total dose can be given in one infusion, single dose administration. Iron 3 carboxymaltose is a ferric hydroxide carbohydrate complex, and the iron 3 isomaltoside has strongly bound iron in spheroid iron carbohydrate particles. Both allow controlled delivery of iron within the cells of the reticuloendothelial system, primarily woman, and subsequent release of bioavailable iron to the iron binding protein, ferritin, and transferrin. The rapid uptake by the reticuloendothelial system minimizes the risk of release of free iron. Okay, this is characteristic for both iron 3 carboxymaltose and iron 3 isomaltoside. And this table show you iron preparation given by intravenous. You can find here hydroxide dextran complex, and you can find here hydroxide sucrose complex, and here carboxymaltose, and here isomaltoside. As a dose of elemental iron for dextran 50 mg per milli, for sucrose 20 mg per milli, for carboxymaltose 50 mg per milli, for isomaltoside 100 mg 100 mg per milli. Test dose required as per manufacturer. In case of dextran, yes. Before every intravenous dose, once before. So, in each time you are going to give intravenous dose, you should do test dose. Okay? Test for sensitivity and so on. But in case of sucrose, first dose, you should do the test, and also new patient on. What about doing test dose for carboxymaltose? No need for test dose. Also no need for test dose for isomaltoside. For route of administration, dextran slow intravenous injection, sucrose slow intravenous injection. For carboxymaltose slow intravenous injection, also for isomaltoside slow intravenous injection. So infusion is given infusion with slow drip. What about the ability to administer total dose? For dextran, yes, up to 20 milligram per kilogram body weight every 4 to 6 hours. Sorry, over 4 to 6 hours. So 20 milligram per kilogram body weight over 4 to 6 hours. But in case of sucrose, no ability to administer total dose. What about carboxymaltose? Yes, up to 20 milligram per kilogram body weight, maximum of 1000 milligram per week, over 50 minutes. Over 50 minutes. Okay. What about isomaltoside? Yes, up to 20 milligram per kilogram body weight, over 50 to 30 minutes. This is as manufacturer said. Okay. So let us go to intravenous iron therapy dosing. Traditionally, the Ganzoni formula 1970 has been used for estimation of iron dose. As you see, this is the formula. It is complex formula. So, however, this cumbersome, prone to error, and can underestimate iron requirement, as mentioned by Dignas et al. 2015. Use of a simplified approach to dosing has been recommended. Okay, what about adverse effects and the cost effectiveness in intravenous iron therapy? Genuine hypersensitivity is rare, and no difference between the risk for hypersensitivity reaction has been identified among intravenous iron products available in UK. In rare cases, fetal bradycardia has been observed in pregnant women with hypersensitivity reaction to parenteral iron. So, those in which hypersensitivity happened was associated with fetal bradycardia also. Okay? Facilities and the staff trained in management of anaphylaxis should be available. And also the antidote or drugs needed to antagonize the anaphylaxis should be available in each center where intravenous iron therapy is given. Okay? And of course, trained staff and all facilities should be available. Hemosiderin skin staining can result from extravasation, particularly if the cannula is incorrectly placed. So please, when you insert the cannula aiming to give infusion therapy for iron, please insert cannula properly and be careful, no extravasation of the fluid, because hemosiderin skin staining, hemosiderin skin staining can result. Women should be advised of this and should be requested to report any pain at the infusion site. Any pain at the infusion site may be a sign of extravasation because it is painful. What about the cost of intravenous iron? Intravenous iron is significantly more costly than oral iron, with costs covering not only the drug but also the support for administration. You refer the patient to a hospital where with trained staff who do follow up during iron infusion, so it is costly. The drug is costly and the care given also carry another cost, so you should know this is a disadvantage, one of the disadvantages of intravenous iron over the oral iron therapy. Okay, what about breastfeeding after intravenous iron? In a study including 65 patients who received therapeutic dose intravenous iron, isomultiside showed a transient increase in iron in breast milk 3 days after treatment. Compared with oral iron, however, the mean iron concentration remained within normal range and the difference disappeared 1 week after treatment. So, the iron concentration remained within the normal range and the difference disappeared 1 week after treatment. So it can be given, yeah. Let us summarize the guidelines here by the Royal College. Intravenous iron should be considered from the second trimester onwards for women with confirmed iron deficiency anemia who are intolerant or don't respond to oral iron. Intravenous iron should be considered in women who present after 34 weeks gestation with confirmed iron deficiency anemia and the hemoglobin less than 10 gram per deciliter. What about intramuscular iron syrup? Some preparations such as iron sorbitex, high molecular weight iron dextran or low molecular weight iron dextran can be given intramuscular. However, intramuscular injection have some significant drawbacks. Therefore, intramuscular is generally not recommended. And I add from myself, intramuscular iron is a crime. It carries many risks. So, I don't prefer intramuscular iron therapy. Why? Intramuscular injection is painful. Also, has a risk of permanent skin staining and is associated with the development of sterile abscess and gluteal sarcoma. So, if I have another route which is more safer, why I'm not using? So either use oral iron or intravenous iron therapy, each one according to its indication. But please don't give your patient intramuscular iron injection. Please don't give your patient intramuscular iron injection because of many side effects. Okay, clear enough? Okay, let us go to the guidelines with management of delivery in women with iron deficiency anemia. Iron deficiency anemia shouldn't influence the mood and the timing of delivery. So, I'm not taking a decision for mode of delivery, vaginal or cesarean, according to iron deficiency anemia. Okay, it is only for obstetric indication or other factors. Okay, okay. So it doesn't affect the mode of delivery or timing of delivery. You should know this very well. Women with iron deficiency anemia with hemoglobin less than 10 gram per deciliter should deliver in an obstetrician-led unit. Okay? Women with iron deficiency anemia should have active management of third stage of labor. As of all of us know, the active management of third stage of labor is associated with less blood loss. Suppose the woman already has iron deficiency anemia. I don't want more loss of blood. So yes, active management of third stage is better than conservative management. That's true to decrease the blood loss. What about postpartum anemia? Prompt recognition of iron deficiency in the antenatal period followed by iron therapy may reduce the risk of postpartum anemia. Okay, so you should be careful during antenatal care to diagnose first iron deficiency anemia, then manage iron deficiency anemia to improve the hemoglobin level. Okay, and if during pregnancy the iron deficiency anemia managed very well, we are reducing the risk of postpartum anemia. Okay, another point, after delivery, women with blood loss more than 500 milli, those with uncorrected anemia detected in the antenatal period, or those with symptoms suggestive of anemia postnatally should have their hemoglobin checked within 48 hours of delivery. So in all these indications, I should do check for hemoglobin 48 hours after delivery. Okay. So what about the guidelines? Women with hemoglobin less than 10 gram per deciliter within 48 hours of delivery who are hemodynamically stable, asymptomatic or mildly symptomatic should be offered oral elemental iron 40 to 80 milligram daily for at least 3 months after delivery. Okay, we should give her iron, oral elemental iron, 40 to 80 milligram daily for at least 3 months. Use of intravenous iron postpartum should be considered in women who are previously intolerant of or do not respond to oral iron and or where the severity of symptoms of anemia requires prompt management. Okay. Obstetric units should have guidelines for the criteria to be used for postnatal red cell transfusion in anemic women who are not actively bleeding. The decision to transfuse women in postpartum period should be based on careful evaluation, including whether or not there is risk of bleeding, cardiac compromise, or symptoms require urgent attention, considering oral or parenteral iron therapy as alternatives. Women receiving red cell transfusion should be given full information regarding the indication for and the risks of transfusion and alternatives treatments. Okay? Consent should be sought and documented in the clinical records. Of course, you should tell the patient if the advantage, the indication for red cell transfusion, and risks also. And if there is alternative treatment, and you should take consent before red cell transfusion. Okay, lastly, the prevention of iron deficiency. There is insufficient evidence to assess the benefits and the potential hazards of routine iron supplementation for all women in pregnancy. There is insufficient evidence to assess the benefits and the potential hazards of routine iron supplementation for all women in pregnancy. This is the end of my lecture today. I hope it was clear enough. This is my books published on Amazon, textbook of obstetrics, textbook of gynecology, contraception handbook, multiple choice question book, medical disorder and pregnancy and the gynecologic oncology. You can find my link on Amazon here in red and my link on YouTube channel in blue here, where you can find another lecture, different lectures in obstetrics and the gynecology, case scenario discussion, guidelines, MCQ, quizzes, ask stations. All these can be found in my YouTube channel. Thank you, everybody. My best wishes for all of you.